Good afternoon, and thank you for joining us for today's panel, Suicide, How to Talk About It Online and Support Prevention Efforts in and Beyond Your Community. My name is Rachel Havekost, and I'm honored to moderate this discussion. Before we begin, I'd like to first thank the Harvard Chan School of Public Health's Center for Health Communication for hosting this panel, and also acknowledge the sensitive nature of today's topic. We will be having an honest conversation about suicide. If at any time this discussion proves harmful to your well-being, please don't hesitate to seek support or contact the National Suicide Prevention Lifeline at 988. To this effect, I also want to take a moment to acknowledge the bravery and resilience it takes to engage in this discussion. This topic affects so many of us in profound ways, myself included. This week actually marks 2 years since my last suicide attempt and 2 years of being self-harm free. I am so grateful to still be here to witness conversations like the one we are about to engage in. It is because of the courage involved to have these hard discussions that I am still alive, and my hope is that we can pay it forward in some small way for you all today. Our goal in this briefing is to equip you with tools, knowledge, and hope to address suicide prevention in your communities. We have two incredible experts joining us today, Dr. Matthew Nock, co-director of the Center for Suicide Research and Prevention. Dr. Nock is one of the leading voices in suicide prevention research with groundbreaking work on identifying and reducing suicide risk. We also have Dr. Jordan Smoller, co-director of the Center for Suicide Research and Prevention. Dr. Smoller is a pioneer in psychiatric neuroscience and has led innovative studies on the role of technology, including AI, in mental health care. Together, we're going to explore three main areas: understanding suicide as a public health issue, reframing conversations around suicide prevention, especially on social media, and the role of innovation, including technology, in suicide prevention efforts. We'll conclude with a Q&A portion to hear from you and engage in meaningful dialogue, so please drop questions in the YouTube comment section as they arise, and we will get to them at the end. Please also be mindful that we can't provide medical or individual advice in the Q&A section. So let's begin with our first topic, understanding suicide as a public health issue. So I'd like to start by asking Dr. Nock to provide us with an overview of the current landscape of suicide prevention in the US for those who aren't familiar.
Sure. First, I want to say, Rachel, thanks so much for hosting this and for sharing about your own history and for being here today with us and leading us through this really helpful and useful discussion. So I'll try and be brief. I could talk for a really long time about this, and I know that I shouldn't. Suicide is one of the leading causes of death in the US and around the world. I think most striking for many people who aren't familiar with the topic is that it's the second leading cause of death in those ages 10 to 35. So the second leading taker of lives among young people in the United States. Although many leading causes of death, the mortality rate has dropped in the past 100 years, that's not true for suicide. The suicide rate today is virtually the same as it was 100 years ago. So you often see in the media people talking about the suicide epidemic, when in reality, suicide's been a problem for a really long time. And we haven't had the same advances and the same improvements that we have for many other leading causes of death. Women are much more likely to think about suicide and make suicide attempts. Men die by suicide about 4 times as often as women, and that's true globally. So there's a fair amount that we've learned about suicide, how often it occurs, what groups are at higher risk. But one point I would make is that it continues to be a really important problem, especially for our young people. And it's been that way for a long time. And so for all those reasons, I'm glad that we're focusing on this today and that folks have joined us to learn more about suicide and try and help have an impact on this problem.
Thank you so much. I think it's really interesting to think about all of the different factors that play into our mental health and what puts us at risk for suicide. Dr. Smoller, can you talk more about specifically how genetic and environmental factors can contribute to mental health and suicide risk?
Sure. And let me first just echo what Matt was saying about thank you, Rachel, and thanks everybody for being here to talk about these important topics. It's really is as you say, it's a public health issue and a very personal issue, obviously, as well. When we think about some of the things that go into risk for suicide or suicide-related behavior, like many things, and certainly many things in mental health, it is complex, and it is a complex mixture of things like our genes, our environment, our experience, and so on. From the standpoint of genes, we know that some of this can run in families to some degree, and there have actually been now genetic studies that suggest that genetic variations in our DNA can contribute to the risk of mental health conditions, of suicide-related behavior. But we know that each of these genetic factors, even when they're there, contributes a small amount on their own, the genetic variations that we see. And there is no suicide gene, and genes are not destiny. And it turns out that, of course, there are many other contributors that vary from person to person. Some of the risk factors that we know a lot about are certainly having a history of mental health conditions. People with things like mood disorders, depression, bipolar disorder have a higher risk, but also a variety of medical conditions that people struggle with. And then a lot of experience-related things about people's lives, some of them early in life, trauma and childhood adversity, and a variety of things that we call social determinants of health, the environment that we're in, the relationships that we have. Another big environmental factor, maybe we'll talk more about this later, is access to the means to harm yourself. Believe it or not, is a very strongly known risk factor, and it's also an important thing for us to think about in prevention. And also, I would say we know that being in marginalized groups like racial and ethnic minorities or sexual and gender minorities are significant risk factors, and we're learning much more about that, in part because we're seeing a rise in suicide attempts and suicide in some of those groups as well.
Thank you so much. There's so many different factors that play a role, and I think oftentimes these narratives can get misconstrued. So I think it's really important we're talking about this, and especially when it comes to some misconceptions and myths. Dr. Nock, I'm wondering if you can talk to us about some of the biggest misconceptions around suicide and how they might hinder efforts to address it.
Sure, very, very happy to. I'd say one of the biggest myths I hear over and over again is the suggestion that talking about suicide increases people's risk. That if we, like we're doing today, if we talk about suicide, if we ask someone if they're thinking about suicide, this is going to make people more suicidal. And it prevents a lot of us from talking to people about suicide. It prevents parents from talking to kids, friends from talking to other friends, romantic partners to talking to each other, and so on. And there's not only no evidence that this happens, there have been experimental studies showing that this does not happen, that asking people about suicide does not make them think about it, and it doesn't increase people's distress. So it is safe to ask people about suicide. And one of the things I'll probably say over and over again today is, if you think someone might be thinking about suicide or might be at risk, ask them. It does not hurt them to ask the question, and in many cases, it can only help. Another big one is that we have no idea why people die by suicide. And I think that maybe this leads to a lot of the stigma that we see. Suicide continues to be a pretty mysterious thing. People don't talk about it. They don't hear a lot about it. So we don't understand it. Studies have shown us, when we ask people who have made a suicide attempt, why did you try and kill yourself? Why did you try and end your life? Far and away, the number one answer we hear is that people were trying to escape what they perceive to be intolerable pain. Psychological pain that comes from depression, that comes from a lot of different places, feeling isolated, feeling hopeless. There we could go on, but a central component of this is, as people report themselves, an attempt to escape from seemingly intolerable pain. And understanding that helps us try and help people in therapy, in community-based programs, in school-based programs, better understand what's leading to their pain. How can we help them resolve it in ways that don't include ending their life. And that leads me to another one, maybe this is where I'll stop, is thinking about, people often say that suicide is not preventable. It happens without warning. There's really nothing we can do. And in fact, it's just not true. 2/3 of people who die by suicide, and this has been shown in study after study for decades, 2/3 of people who die by suicide told someone ahead of time. they were thinking about death, they were thinking about suicide, they were thinking about ending their life. So certainly there are instances, there's a third of cases where people never told anyone. And so every suicide right now is not preventable, but a lot of them are, because people are reaching out to others and telling them they're having thoughts of suicide. 50%, half of people who die by suicide saw a clinician in the 4 weeks before they died. So people are coming in and visiting their doctor's office, visiting their psychotherapist, visiting their social worker. So there are opportunities to try and help people. And we also know that there are some treatments that work. And we can talk more about cognitive therapy and dialectical behavior therapy. There's specific forms of talk therapy, of psychological treatments that have shown an ability to cut in half people's risk of suicide attempt. So there often is warning, and there are things that we can do to try and to decrease people's risk of dying by suicide.
Thank you so much. And I think that last statistic you shared, that 50% of people actually go in to speak to someone, I think that highlights that people do want to seek support. And I think it also highlights that there is likely a lot of stigma still that exists and reasons that people aren't seeking support. And so, Dr. Smoller, I'm wondering if you can talk about systemic challenges that contribute to these misconceptions, and maybe some of the things that get in the way of people seeking support, and why suicide prevention really is a public health priority.
Yeah, sure. Well, I think that's absolutely right, that, people are unfortunately dealing frequently with stigma related to mental health conditions in general. I think we've seen some improvement in that, and more discussion publicly about mental health. But it's certainly true that stigma persists. And to the extent that people do feel like they feel shame, or they're worried at what people will feel or think about them, it inhibits them from either just talking to somebody and sharing the thoughts and feelings that they're having, or certainly seeking care. People may be worried that if they seek care, they'll suddenly enter a cycle of treatment that is going to be very intensive. That may not be the case at all. And I think that unfortunately the stigma is not only felt by individuals, but there's some degree of stigma attached to mental health care and its funding and its support with, access to healthcare providers and access to insurance reimbursement that sort of limits to some extent the ability that people have to get care. I think, you can certainly, I'm sure, resonate with this, but once one does get access to good care or have that ability to talk to people, the relief and the possibilities that come with that are something they didn't expect, and can be very helpful. So it is unfortunately true, and I think the folks on this who are watching today can be part of the solution in reducing that sense of stigma and normalizing conversations about mental health.
Yes, definitely. And I think on that topic, I'm going to use this as a segue to move into our second segment, which is all about reframing the conversation and community-based interventions. And Dr. Smoller, I'm going to ask you to sort of just follow up and talk about how can we reframe conversations around suicide prevention, especially on social media, and maybe what are some best practices that our audience can use when promoting safe and supportive dialogue online?
Sure. Well, this is really important. It's obviously just increasingly important in the last, decade. The rise of social media as the dominant way that many of us get our information means that those of the people listening here who are creators, let's say, have a real role to play, and things can go in many different directions. So it is possible to really enhance the conversation, to really focus on evidence-based information about suicide or mental health. But at the same time, there's the possibility of exacerbating or worsening the situation if we're not following best practices. And this is a new area, so it's one in which we're still learning a lot. But there are some basics that a number of organizations, including the American Foundation for Suicide Prevention, which I think we're going to link to and have some materials for folks who are interested, a very trusted source. They and others have talked a little bit about the importance of how you communicate about some of these issues. For example, for journalists, but also for social media folks. And in terms of social media, I think that there are a few basic and important issues. You want to sort of provide a sort of content notice, like you did, Rachel, at the top here, that, if you're sharing something, it may be triggering or difficult for certain people, and you want to give people the opportunity to scroll away or do something else. If you're thinking about reporting on research, you want to take a look at what it is you're reporting on, and before posting it or coming to some conclusion about it, do a little bit of research about where is this information coming from. There are things that people have talked about in terms of language, how we even just talk about these things that are sometimes really important. For example, people used to say committed suicide, for example, or made a failed attempt at suicide or something like that. We don't use that language, in part because it's sort of from an outdated idea that when suicide was actually a crime, and we think very differently. So we talk about that somebody may have died by suicide or took their own life or made an attempt. You want to stay away from graphic information or sensationalizing anything related to self-harm. We worry a lot about that. You want to be humble about the causes. So if you're talking about what led to an event, or you're talking about, let's say there's something in the news you're responding to, or even just a friend, when you're talking to them, you can't presume that you really know the causes. And as we talked about earlier, these are very complicated kinds of scenarios, and there isn't a single cause for people. So I think those are some of the important things. And you want to, I think, always provide that message that help is available, that recovery is possible, and actually give resources when you can, like 988, the crisis lifeline that is available 24 hours that we could talk more about, so that people have somewhere to go if they're thinking or having difficulties.
Thank you so much. I think that's really important, especially for a lot of folks watching, myself included, because I often get anxiety about, is what I'm going to share be more harmful than it is helpful? And I also appreciate what you said at the very end there, because I know for myself, when I'm going through a hard time, it's hearing stories of someone who's overcome and saying it's okay, like it's going to get better, like having that hope and feeling like I'm not alone opens a door for me to keep going. So like on that sort of note, I'm curious, either one of you can answer this question about either school-based programs or peer-to-peer support, or how there's conversations happening at those levels in schools to strengthen support systems about this topic.
Sure. Well, one thing that there has been some research on is that school education programs that educate about the problem, especially when they're actually engaging or educating students themselves, can be effective and can help to reduce risk. At a broader way, I think, as Matt was alluding to, the kind of connections that we have to each other and the kinds of opportunities for conversations can be really meaningful. And we know that social connection and social support is actually one of the most protective factors. So when people feel like they are connected and that they have somebody who is supportive, who is non-judgmental and listening, that's a really important thing. And there are, in fact, programs that leverage that, where either people through nonprofits or through other community organizations have developed peer-to-peer kinds of programs that people find really helpful. And so I think that kind of community engagement is really important. And when we talk about how do you have these conversations? It's not simply talking about it. As Matt said, it's not dangerous to have a conversation per se, but you do want to sort of think about how you're going to do that, especially if you're talking to people, friends or somebody that you are meeting one-on-one. You want to create a safe space. You want to be able to talk to them in private. You want to express your care for them, and certainly be asking the kinds of questions that we talked about earlier. But then also, being available to encourage them to seek treatment or to reach out to a lifeline or to contact their doctor or their therapist, and be that kind of support that actually can be really helpful for people.
Yeah, I would just add to that I totally agree. There's a huge role to play for peer support in suicide prevention, and part of the reason I was especially excited about this conversation and many of the folks who are on this in this meeting who are on social media. There's one survey that found that when people are asked, who do you go to when you're distressed, only about 5 to 10% of people said, I go talk to my doctor. Closer to half of people said, I go and talk to friends, peers, people in my community. So people struggling with depression, with anxiety, with suicidal thoughts are telling us pretty clearly, we as clinicians have a role to play, but there's a much bigger role to play by people listening, those around members of the community. So there's a very big role to play. I think there's a lot of excitement now in the research community about the possibilities that are now available with folks being so online. There's a lot of concerns about, is being online, being on social media, being online in general, associated with increased risk of feeling isolated and anxious and depressed, and does it increase risk of eating disorders and suicidal thinking? There's also a lot of excitement about the potential of reaching people where they are, when they are in need, and helping out to them. And we're in the process of trying to figure out how do we best do that. A recent study was done in collaboration with a platform called The Mighty, where it's an online community of people who, anyone in the community can post about experiences they're having. And there's a segment of the community focused on suicide, where people will post saying, I've struggled with suicidal thoughts and I'm still here and I'm happy that I worked through this. And others say, I lost someone to suicide. And let me tell you how difficult it has been. What we found is that people who read those posts, certain kinds of posts, show a decrease in their suicidal thinking, and an increase in hope and optimism and feelings of connectedness. So that seems to be how these stories are having a positive impact. So we know, and this is an experimental study, we know that these sharing these kinds of stories, sharing this kinds of information in online communities can be really beneficial. I think a trick moving forward is figuring out, and maybe folks on this call, on this line can help, figuring out how do we optimize that and get it to work and get people to it and get people using it in ways that lift members of the community in a positive way.
Thank you so much. I feel like for myself, that was a huge movement towards recovery in a lot of capacities. Is at least for me, it was being in group therapy. It was being surrounded by other individuals who were sharing similar stories and knowing that I wasn't alone. And that allowed me to lean into then actually talking to my doctor or talking to my therapist, because I felt like there was less shame associated with it, because there were all these other people who were experiencing the same thing and also seeking help. So thank you for pointing that out. Okay, I'm going to switch us to our third segment, which is innovation in suicide prevention and the role of technology, which I'm super curious to hear about. So Dr. Smoller, can you tell us a little bit about how AI is being used to predict and prevent suicide?
Sure. Well, this is an exciting time, and I think we hear about AI everywhere now, and AI has been part of our lives actually probably for longer than we appreciate, because many companies have used it to figure out what is it we want to see and what do we want to buy. But many of the same technologies we can use for advancing health. And one of the major questions, and as we think about preventing suicide, is knowing really who is at risk. One of the things that the amount of data and the things like AI technology now bring is that we can leverage that, those data, particularly in healthcare settings like where I am, to do better than we've been doing in identifying who is at risk, and then maybe be more effective at providing preventive strategies. So as Matt mentioned, most people who attempt or die by suicide have seen a healthcare provider in the month even leading up to the event. Like most people, clinicians or healthcare providers like me are not that good at knowing really who is at risk. And that's because there are so many factors at play, so many variables involved. We don't know what most of them are or how much weight to give them. So in some ways, that's the kind of thing that AI can be particularly helpful for. We can use big data, for example, health record data, and develop algorithms that can do better than clinicians in many ways at predicting risk, although we always, combine them with clinical expertise. And one of the things that we're doing in the Center for Suicide Research and Prevention is actually testing whether some of these approaches can be useful, let's say in an emergency room when somebody comes in and is at risk. If we have the benefit of also using AI, can we do better at knowing who really is at risk, and then pairing that with what we already know are effective strategies for prevention? AI is one form of technology, and health records are one, but there's also this explosion, obviously, of digital data through smartphones, through social media. Sometimes people have been able to use that kind of information to determine who's at risk, or to actually deliver interventions that may be useful at times when people really need them. And that's another thing we're testing in our center. And so, can you deliver through the smartphone something that would be helpful to somebody when they really need it? So all of these new technological opportunities have some real potential upsides.
Wow, that is fascinating. This is something that I am definitely really still learning a lot about. And I imagine people in the audience also have similar questions, just about, I think Dr. Nock, you talked a little bit about this earlier when it comes to, the space between social media and research and how we kind of bridge these gaps and the ethics behind all of that. So I'm wondering if you can talk about some of the ethical challenges that we need to address when using AI for suicide prevention.
Yeah, I'd be happy to. It's something that we think a lot about. Our goal is to try and find people who are at risk for suicide, who are having thoughts of suicide, and intervene to keep them safe. And there are ways that we can do this that we think would improve our process, but we bump into questions about, should we do this? Is it ethical? I'll give it to be concrete. As Jordan was alluding to, we can look into patients' electronic health records. So I go to the doctor, I should go to the doctor once a year, twice a year, and then they write down things in my chart. It turns out that if we write algorithms, if we write machine learning algorithms that go across all of the little codes in my chart, we can predict with a pretty high degree of accuracy whether I'm going to make a suicide attempt in the next month. Surprisingly high degree of accuracy. Should we do that? Most people would agree, sure, we should do that. You're using my health information to predict my behavior and improve my health. Fine. But we also know that if I increase my consumption of alcohol, that increases my risk. If I go to Whole Foods and start buying alcohol and scanning my little card on my keychain, advertisers can get that money. It turns out if we pipe that money in, those data in about you're buying more alcohol, or there's a lien on your house, or you have a domestic violence charge against you, advertisers can get that information. If we get that information and pipe it into our model, we can predict more accurately. But the question is, ethically, should we? Should we use those data for your healthcare? So there's questions about what data can we get and should we use them? And there's related questions about how do we share information? So using the model I just described, should we then share with your primary care doctor when you go in that you're at high risk? Many people would say yes, but should we also tell that person that you're buying more alcohol at Whole Foods? Probably not. That seems like it crosses a line and gets into people's private everyday life in ways that probably we shouldn't do. And to be clear, we don't. But we're not just doing advertising. We're trying to provide better healthcare and improve science. And so we have to make sure that we're doing this in ways that are really ethical and are okay with people, ourselves included, and not increasing risk in various ways. There's also questions about beyond your doctor, who we share information with. Should we share information? If I'm at risk for suicide, should that be shared with my spouse, with my parents, with my children, with other people around me who can keep me safe? Logic would say to most of us, yeah, we should do that. But there are pretty well documented examples in the literature of when this has been done, and it's caused more harm than good. There was a pretty well-known example of when there was an app that was built to find people on Twitter who were posting about suicide and intervening with people in their network. And it was pulled down pretty quickly because that was actually increasing people's risk, because the bully in the network got word from the app that I was thinking about suicide, and then the bully started bullying me even more as a result. So things that are well-intended don't always cause good. And so we as scientists really are driven to experiment with everything that we're doing, make sure that's ethical before we experiment, and then experiment and make sure that it's not harming people as a first principle, and hoping that it's helping. And if it does, then and only then do we disseminate it and make it available to the broader community. And there's also a lot of questions now with AI about, digital interventions and the role of chatbots and generative AI and ChatGPT and so on. And there's a lot of efforts right now in the community, the scientific community, the startup community, to build chatbots that can interact with people and help them. Very well intended, but we've got to be careful. I'm not saying we shouldn't do it, but we should be really careful and I think scientific in the process, and make sure that we're not causing harm to people. There's been a lot of pushback from the community on social media about efforts to use chatbots to help people in distress. And on one hand, people say, but many people in distress, by one study we did, 40% of people who posted online about suicide had no response from anyone in the social media community. That's heartbreaking. So chatbots could help us reach those people. On the other hand, a chatbot, I think most would argue, is not the ideal response to somebody who's suicidal. It's another human. So perhaps we should use chatbots and AI ethically to be in the loop, and to bring other humans into the loop to help. So there's a lot of excitement, but there's also a lot of ethical aspects to think through to make sure that we're doing this in ways that are helpful and not harmful.
And the one other thing that comes up often is, if you have algorithms, let's say, how do you know they're not biased, and how do you know that they're not going to? Because as many people may know, when you train an algorithm on data, you're essentially learning what the patterns are, and what, in this case, what are the patterns that lead somebody to be at high risk, let's say, for attempting suicide. But if there are biases in the way our society or our healthcare is provided, you're also learning those patterns, and you don't want to recapitulate those patterns. And so we and others spend a lot of time looking at that and trying to identify and, to the extent possible, remove any biases that might be there. But that's an active area that we need a lot of thought about as well.
Thank you both so much for thinking about this topic in such a delicate way, and understanding the nuance and the fact that it's not a black and white conversation, and that when we think about how we introduce this conversation into the world of social media and technology, that we still need to be ethical and mindful when approaching it. And so I'm just really grateful for both of you, and for your minds, and for being here and answering these questions. We are going to now kind of transition into audience Q&A, and I have one that's kind of for both of you to start us off. So the question is, do we see a correlation between increased social media use and suicide?
Yes. There have been a number of papers, scientific papers published in the literature. This is going to be a yes and, or a yes but. Number of papers published showing that there is a correlation, to answer the question concretely, between social media use and suicide. This seems to be the case over time. As social media use has increased, so has suicidal thinking and suicidal behavior, especially among young people, especially among younger girls, and within people. As we see social media use, and particularly problematic social media use, many hours of use in a given day. As we see the number of hours of use increase, we see increases in depression and anxiety and sleep problems, and it seems suicidal thoughts and behaviors as well. But as with any correlation, that doesn't necessarily imply causation. And so there's a lot of work now trying to figure out in what instances, among what kind of people do we see stronger correlations between social media use and suicide? What kinds of interactions online might really increase risk? And so I think most in the scientific community would agree there's definitely a correlation, and we're trying to better understand to what extent there's a causal association here.
Yeah, it's such a hot topic, obviously. And as Matt was just saying, you know, if you look at the curves of, let's say, rates of depression in youth or anxiety, it really tracks pretty well with the, you know, the advent of smartphones and a lot of social media use. But I totally agree with Matt saying you can't quite be sure. A lot of things have increased over the last decade, obviously, that also coincide with, you know, rates of certain cancers or things like that. It's very difficult to know exactly what that link is, but I think the important point also is, I think what Matt was alluding to as well, which is, you know, it depends on the kind. It depends on, it's again a sort of nuanced thing. We talked about connection being important and a protective thing, and obviously social media at its best is a, you know, supportive and connecting kind of thing for people, and for some people that's incredibly helpful. On the other hand, clearly, there are ways in which, you know, sort of toxic comparisons or bullying or other kinds of things that actually isolate people can be detrimental. It sort of follows the known risk factors. And so it really matters. And in the case of suicide in particular, I think, as we've talked about before, how you talk about it actually does matter. And so when it comes to actually content that relates to this particular area, knowing those best practices, trying to be mindful and thoughtful about whether what you're saying or doing is likely to be helpful to people or not is really, I think, important.
Thank you both so much for answering that question. We have another one that is for both of you, or either to answer from the audience. The question is there any place in the world where suicide is actually decreasing? And if so, what patterns are we seeing there that seem to be helpful?
Yeah, it's a good question. I mentioned the suicide rate in the US is the same as it was 100 years ago, but there have been ups and downs. And this is true globally as well. So the suicide rate, there's been a lot of media around the fact that the suicide rate has increased pretty consistently over the past 20 years. In India, for example, it's decreased over that same time period. If you go back between 20 and 40 years ago in the US, the suicide rate decreased. So country by country, suicide rates will ebb and flow a little bit. Overall, as I mentioned, the suicide rate has been pretty flat. We've been trying to understand, well, what's causing those ebbs and flows? Perhaps there's things in the environment, things in the world, things in the community that are leading to those changes. And to date, we don't have a really good understanding. There's been very few really big, clear effects that have led to decreases in national or global suicide risk. It's what we're striving for, but we're not there yet.
And you know, there are some cases that sometimes the change in suicide rates gives us clues about what can be helpful. There's a famous example in Denmark where the suicide rate was, you know, one of the highest in the world. And there was a concerted effort made that included things like what we call means restriction, trying to make sure that people didn't have access to things that might, if they were feeling suicidal, might result in their actually taking their own lives, as well as a real investment in services and suicide prevention clinics and psychiatric services. And that actually resulted over years in bringing their rate substantially down. So sometimes it's very informative where and when rates go down.
Oh, it's fascinating. I didn't know either of those about either of those countries. So thank you for sharing that. Okay, our next question how does having a stroke, which alters the functioning of the brain, play into suicide risk and prevention? And while discussing this, could you also include how traumatic brain injuries play into suicide risk?
Sure. Yeah, I mean, those are both conditions that have been linked to an increased risk. It's again probably multifactorial, as we would say. So there's the actual injury potentially to the brain, which can have effects on mood and thinking, might make people less inhibited, let's say, and more impulsive. So those are some direct brain effects of injuries to the brain, either stroke, which is kind of a vascular injury to the brain, or traumatic brain injury. There are other things that are what we would call the consequences of adapting to some of the impairments or restrictions that people may face, the medications that they may have to take that can also feed into that. And this is an area where, particularly, for example, in traumatic brain injury, there's been a lot of work in both sports and in the military. And for example, traumatic brain injury often results from trauma, obviously. And so there are all those elements related to somebody experiencing the trauma. Sometimes it's, or not maybe infrequently, in certain settings, related to developing PTSD as well, which carries its own risks. But those are two examples, certainly, where there is an increased risk. And I think part of how does that play into prevention and risk assessment? It's important for healthcare providers to know about this so that they can, be aware that there may be added risk. And many times people need kind of comprehensive care, not simply the care of the neurologic, problem that they've suffered, but also mental health services or support. And that can be very helpful. Matt, you may have other thoughts as well.
You covered a lot of the things that I was going to cover.
Great.
Thank you so much. Okay, this next question says, in your research, and I'm guessing this goes to both of you, what have you found are the greatest risk factors for suicide? More simply, what should I be looking for so that I can better show up for my community?
Yeah, I'll jump in and start, and Jordan, then you cover the things that I've missed. We've done a lot of work as a community, a scientific community, to try and understand risk factors and periods of risk, and I'll try and summarize as best I can. And part of this work has come from working in this really large collaborative cross-national network of researchers through the World Health Organization, World Mental Health Survey Initiative, where we're looking at three dozen countries around the world, looking for some sort of universalities about suicide. We see that thoughts of suicide are pretty much absent in childhood and then skyrocket in adolescence. In virtually every country we examine, there's a big increase in suicidal thinking during adolescence and young adulthood. It's a period of increased risk. About a third of people who ever have thoughts of suicide make an attempt, only a third. The risk of making an attempt is highest the first year after a person starts thinking about suicide. So we want to look at adolescence. We want to look at right after someone starts thinking about suicide, risk is the highest. The things that predict thinking about suicide, mental disorders are the strongest category of risk factors, and depression is the biggest one among them. So being depressed, having a family history of depression really increases the person's risk of thinking about suicide. And impulsive behavior and mental disorders characterized by agitation and poor behavioral control predict acting on suicidal thoughts. So the combination of depression and poor behavioral control, that can be aggression, that can be alcohol and substance use, that can be all kinds of different disinhibition, really increase a person's risk. So it's a long-winded answer, and it's in part because, as Jordan mentioned earlier, suicide really results from the combination of lots of different risk factors. There's no silver bullet. There's no one thing to look for. But if I was going to look for categories of factors, it's adolescence, and also later in life. There's a really big spike, especially in older white men in the US. And in between, it's mental disorders, especially depression and trouble with impulse control and aggression.
And one other thing just to add is one of the the things that we can do potentially a lot about, that is a big risk factor, especially for death by suicide, is access to lethal means. And so one of the things that, you know, is really important are gun safety or other ways of removing firearms if somebody is at risk, or other means that might be you know, available to them when they're feeling at their worst. And that turns out to be you know, really important.
Thank you both so much. We have one final question that is asked to all three of us, so I'm happy to answer first. The question is, if you could have a content creator share one thing about suicide with their community, what would you want it to be? I think for me, I sort of said this a little earlier, so I'll echo it again, is it's just knowing that there's hope and that it gets better. I think hearing people share, even without any description whatsoever, just that it gets better, it really can just keep me going one more day. And so having messages of hope and reminding me that I'm not alone, that for me is usually the most supportive thing to hear as a consumer.
Yeah, you said it. This is people often describe suicide as a permanent solution to a temporary problem. And we have data on this. You know, most people who think about suicide won't think about it beyond 1 year. They'll have thoughts of suicide, they'll go away, they won't come back. Many people will have thoughts that last longer, but the majority don't. So it's a temporary thing. And we've done smartphone monitoring of people at risk. It's an episodic thing. Not to minimize it. It's intense, unbearable pain, the worst pain a person could experience. And for most people, it doesn't last forever. So I totally agree, Rachel. You know, convey that message of hope, and also try and open up communication. One of the toughest things about suicide, I mentioned 2/3 of people who think about suicide tell someone, but about 80% then deny it and say, no, I'm really not suicidal. And sort of that not knowing is really difficult. Virtually everyone I know who has lost someone to suicide, myself included, wishes the person talked with me about it. But that's the opposite of what many people experience when they have suicidal thoughts. They don't think people want to hear it. They don't share it. And so sorry, I've said a lot of things. You said say one. The one thing I would say is to talk about it, encourage others to talk about it, remind others, express to others that there is hope and that there is support.
Yeah, I would agree with that. I think what both of you said is just so central, that suicide is preventable, that there are resources out there and in fact, the 988 line is a resource anybody can use at any time if they need it, and that social connection and connection to care if you need it makes a huge difference. And so, you know, hopefully we're going to start to see the tide turn in the next few years and do better than, as Matt, you know, began with, you know, the sort of a flat, no change or even increases in recent years. This is the kind of discussion I think that can help move the needle.
Thank you both so much. And thank you so much to our audience members for your thoughtful questions and for being a part of this conversation. I encourage you to download the Suicide Prevention Toolkit, which will get sent to you. It has actionable resources to help you share information with your communities online, including information like the 988 hotline and other resources as well. Thank you again to Dr. Nock and Dr. Smoller for your expertise. And thank you all so much for being here today.
Thanks so much.